I'll be discussing tuberculosis diagnosis, the WAIOT view. Diagnosis of tuberculosis, any tuberculosis, generally has two components. One is clinico-radiologically one suspects, and then some tests like smear, gene expert, histopathology, and of course, TB culture, which could be ELSE or midget. The gold standard is TB culture. While there are some peculiarities of osteoarticular tuberculosis, as the bacilli travel from lungs to osteoarticular system, the oxygen concentration goes down. With that, they become facultative anaerobes as against the obligate anaerobes as found in lungs. They become posibacterial, posibacillary, and less active. Thus, the culture yield decreases significantly. Therefore, diagnosis of osteoarticular tuberculosis is more challenging than diagnosis of pulmonary tuberculosis. We at WAIOT decided to study perceptions and practices in different parts of the world as related to tuberculosis. We reviewed several papers and suggested a way forwards in a publication titled Diagnosis of Osteoarticular Tuberculosis, Perceptions, Protocols, Practices and Priorities in Endemic and Non-Endemic Areas of the World, a WAIOT view. Now, I'm sure you must have come across such presentations, a sinus or an ulcer. With such clinical presentation, the course of action differs in endemic and non-endemic areas. In endemic areas, there is a large patient load and improved perception of osteoarticular tuberculosis. However, very often the facilities are poor. Therefore, the most prevalent practice is starting anti-TB drugs on clinico-radiological or at the most histopathological diagnosis. This has a problem of missing resistance as well as TB mimics. On the other hand, in non-endemic areas, the patient load is less, but at the same time, the perception is less. That leads to samples that are not routinely sent for TB culture, and therefore, it is often considered as a diagnostic enigma and which leads to significant delay in management. Coming to endemic areas, missing mimics is quite common. This was a study published in 2009 by us, and we studied various patients from all over Mumbai. And out of 93 patients who were on threshold of starting ATT or were not responding to ATT, 13% did not have tuberculosis, the commonest being pyogenic infections or even metabolic bone diseases. Therefore, we decided not to assume tuberculosis as the only diagnosis and do all the tests. Missing resistance is equally common in endemic areas. This was a 23-year-old man who presented with discharging sinus and ankylosis of elbow for off and on for several years. At present, he was on anti-TB drugs continuously for 5 years and intermittently for 9 years. Tracing the history, 1999, he had pain in the elbow. He was operated and diagnosed as TB based on histopathology. He was started on anti-TB drugs. 98, the lesion recurred. Therefore, exploration and arthrolysis of elbow was done. Anti-TB drugs were continued. 2002, again he had a sinus, again he was operated. 2006, again he was operated for a discharging sinus. 2007, by then he had developed multiple sequestra. Again, histopathology was done, which showed COX, and he was treated on modified ATT. He presented to us in 2012 with a discharging sinus for many, many months with a significant destruction of lower end tumors. We did his debridement and histopathology and culture. Culture grew Mycobacterium tuberculosis complex, and TB, osteoarticular TB, was diagnosed beyond doubt. However, it is not enough. One has to find out the sensitivity for drugs. And he was resistant to isonics, rifampicin, pyrazinamide, ethambutol, and streptomycin. And he was on these drugs for a long, long time. He was susceptible to following drugs, and therefore he was treated with moxifloxacin, clofazimine, PAS, ethionamide, and cycloserine. 2013, he was radiologically and clinically fine. The ATT was continued for 24 months, and this is him at 7 years, no recurrence of symptoms. So for the first time in 16 years, and after several surgical procedures, his TB culture was done and was positive. Antibiotic sensitivity could be done, and he went beyond simply diagnosing TB and could give appropriate therapy. This was also brought out in another paper that we had published. It is not enough to diagnose TB. Drug sensitivity needs to be done. Another large series that was published from Mumbai, drug resistance pattern in Mumbai, 686 culture positive patients were analyzed in the tertiary center, and 16% of them had drug resistance. And therefore, just diagnosing tuberculosis is not enough. In endemic areas or all over the world, drug sensitivity needs to be done. Thus, in endemic areas, change of mindset is needed. Equally important is improving infrastructure and improving culture yield is needed. What about green areas? There's a big warning that was given in this paper long ago. The prevalence of tuberculosis is increasing in developed countries. Various reasons have been noted. Just to give an example, this paper says that there is a significant delay by patients as well as doctors in Netherlands. Paper from Italy says that the mean delay until diagnosis was almost 200 days. A paper from United Kingdom analyzed 31 patients over 2 years. And in them, the typical symptoms of TB, such as fever, sweats, etc., were not common. There was a delay of 7 months for referral to specialist center and a further delay of 2.3 months till starting treatment. But the most noteworthy fact was 7 out of 31 patients. In 7 patients, the biopsy specimens were not sent for mycobacterial culture and they needed a second biopsy. So that is very, very important. And hence, the authors suggest that mycobacterial culture is to be requested for any patient in whom infection or malignancy is suspected or where there is a clinical uncertainty. So what did we conclude? We concluded that the term clinico-radiological diagnosis be replaced with clinico-radiological impression because it is important, a starting point for initiation of investigation, but not a starting point for initiation for ATT by default. We should aim for complete diagnosis in every case. That means culture as well as drug sensitivity pattern. Some patients may qualify for ATT. ATT may be initiated under supervision if complete diagnosis cannot be established based on strong clinico-radiological impression, but it is just that they qualify for ATT. Lastly, avoid empirical modification of ATT in non-respondents. Try and obtain most appropriate samples and repeat all the studies. So to conclude, friends, in endemic areas, avoid starting ATT as a knee-jerk reaction. Investigate well. And in non-endemic areas, remember there's a disease called osteoarticular tuberculosis. Thank you, friends.